Myself, Dr. Antony Wilson. Thank you for giving me this opportunity, Dr. Y.V. Reddy, sir. So I am going to present regarding intravascular lithotripsy.
We take this opportunity to thank Dr. Y.V. Reddy for being the organizing secretary for this program, sir. Thank you very much, doctor.
So from morning we are talking about always calcium. Once upon a time it was, oh my God, calcium, how I am going to tackle. Nowadays, oh, calcium, we can take care. So for interventional cardiology, very important, before going to the procedure, so a clear plan about what you are going to do, what instrument you are going to use. So you can expect in the procedure, what are the complications, how you are going to tackle. If you are having in your mind, then it will be very easy. So if there is calcium, there is a 20%. Most of the interventions are very difficult with the calcium, and from where it came actually, we are routinely used for renal calculi. That intravascular lithotripsy was normally lithotripsy was done to crack the renal calculi. From that it was adapted, and you can see this is the IVL machine, and you can see the generator, the bigger one, and you have the connector cable, and you have the push button which will give pulses. Normally one cycle contain 10 pulses, maximum 80 pulses you can give, and this will be a IVL balloon catheter. So what is the mechanism basically? So it will have the two emitters in the balloon, and it will give electric spark. It will change into acoustic pressure by forming the vapor bubbles. So it will import on the calcium and it will crack it, and it will give approximately 50 atmosphere pressure and a positive pressure, and with a minimal peak negative pressure. So that it will cause less tissue injury. So what is the step of use? So first you need to identify the lesion. So most of the time it is a bulky balloon, and it starts with a 2.5 mm balloon and up to 4 mm, and the length will be 12 mm. So once if it is a very tight lesion, we can't take directly to the IVL balloon. So we will pre-dilate with a normal non-compliant balloon. Then we will select the size of the IVL balloon with 1:1 ratio, and we'll load the catheter, and we will inflate up to 4 atmosphere pressure with the 50-50 saline and contrast in the inflator. So we will deliver a single cycle means 10 pulses. Depends on the lesion, you can go to up to 80 pulses, and we can inflate up to the 6 atmosphere pressure and till cool down phase. And we can repeat as necessary, depends on the lesion. So here you can see the OCT image. Whenever the arc more than 180 degree, or length more than 5 mm, or thickness more than 0.5 mm, it is very important calcified lesion. It needs special techniques. So here we can see the 360 degree calcium in the OCT image. So after the post IVL, you can see the crack. So it will give compliant to the stent after deployment, and it will give good minimum stent area post deployment. So one thing you can see whenever you are giving the pulses in the IVL balloon, you can see the spikes. It will call shock topics, and most of the time it will be asynchronous spikes. It won't capture, but whenever the patient had heart rate less than 60, that time it may capture, but there is not that much. It will be a transient one only. So compared to other calcium modifying instruments, it is less risk of perforation, and you can able to keep a body wire, because in rota you can keep the body wire, it will cut also. So for the support and all, you can keep the body wire in a IVL balloon, and you can modify the calcium in large vessel also, and the ability to impact deeper calcium, not with other modifying instruments. You can do only a superficial calcium, and its ability to navigate tortuous anatomy also. But if a rotabarundal, very difficult to take a tortuous anatomy, and there is no wire bias which is in the rotabar. If it is wire bias, either one side calcium only, you will be modifying, not in the entire vessel. But this IVL balloon, it will act on the circumferentially, and you can modify without no wire bias, and there is a low risk of dissection. So I'm going to show two cases done by Dr. Y.V. Reddy, which I assisted with him. And this is a 69-years-old male patient, diabetic dyslipidemic, post-PTCA to LAD in 7 years ago, and presented with us with a effort angina and with a LV of 46%. You can see the RCA. There is a proximal tight lesion, and in the mid also, and in the distal part of the lesion also. So what we done initially, we done PTCA to the distal two lesions. We used guideliner because it was very tortuous and very tight calcium lesion. We couldn't take the balloon and stent also initially, so we took the guide liner and we took the stent. We deployed 2 stents in the mid and distal. What about then the proximal lesion? You can see the dog bone effect. There is an IVL balloon with 3.5 into 12 mm shockwave C2 IVL balloon. Once we delivered the pulses, you can make out that lesion become well expanded. After that, we deployed the stent, and final result you can see. It's very good result we got it. In the second case, there is a 52 years old female, hypertensive, diabetic, obese, dyslipidemic, and status post CABG in 2016 with a single graft limo to LAD. Now present with the effort angina for 3 weeks and with a normal LV function. In the CT angio showed a closed limo to LAD graft. So we plan to tackle that LAD severely calcified lesion. So we initially tried with a normal NC balloon. As you can see in the first image, it was not opening at all. So we took a 0.75 into 10 mm alveolar balloon for an initial pre-dilatation, because with this tight lesion we can't take the IVL balloon. So we took a rotabur, 1.25 mm rotabur, and we went on run. Then after that we had enough space to take our IVL balloon. So we gave 2 to 3 pulses in the distal part of the lesion, and in the proximal part of lesion 2 to 3 pulses. Then you can see the well deployed stent, the area also. So you can see the final result of the image. So well expanded stent in the LAD osteoproximal lesion. So my conclusion, coronary IVL system is a promising new treatment modality to tackle moderate to severe calcified coronary lesion with a high rate of success and a low risk of complications. Thank you.